Hello, my dear doctor. Welcome to the nephrology slides. And one of the important lecture discussions here, some of the photography and some of the slides in nephrology system, the questions will be come up, and some of the slides will be embedded onto different questions. So these lectures will have tremendous effects to know the facts that you already learned on the video lectures, my dear. And you will have the practical views of some of the important differences, some of the important structural abnormalities that happen of the different disorders, especially the glomerular disorder and some of the histopathological slides, my dear. Knowing these facts not only will be helpful, my dear, to do, of course, giving the answers, the questions correctly with the confident, and also will have the tremendous effects in your clinical practice. Yes, my dear doctor, let me start by showing the nephrology slides. And first slide stands on the normal glomerular structure, and it has some of the diagrammatic pictures. Before going some of the abnormalities, knowing some of the diagrammatic things, that will be really helpful to cleanse some of the abnormal pathology that you'll get in the different slides. So let me start by some of the normal glomerular structure. So glomerulus is nothing but a tuft of capillaries, my dear. The blood vessels, that's it. And the blood vessels will have some of the endothelium, basement membrane, and also the epithelium. So some of the tuft of capillaries, the 2, 3, 4, 5, and numerous capillaries within Bowman's capsule. So if it is the cross section has been happened, so you'll see here with the 3 capillary are seen here. So within the capillaries you see more magnification so that you can understand. So within this there is a blood with RBC, and these are the endothelial cells, and this is endothelial cells, one of the cross section that happens. So this endothelial cells. So other cells look like something like that. So these are endothelial cells. Immediately after the endothelial, this is basement membrane, right? Light blackish color. So this is a basement membrane. So yes, my dear, so this is the lumen, and this is the red blood cells. This is endothelial cells. This is basement membrane, and outside the basement membrane, these are nothing but the epithelial cells. All are epithelial cells, and these epithelial cells having some of the food processes. Yes, now the food processes, and some of the epithelial cells having some of the podo, one of the leg that we call the podocytes, and this is the podocytes. So this is the structure once again, the lumen. This is the endothelial cells, and this is one of the cross section that happen, the endothelial cell, endothelial cell, endothelial cells. So endothelial cells. And outside this is a light color. This is the basement membrane. This is the food processor epithelial, and these are epithelium, and these are the podocytes. So outside of these 3 lumen or 3 capillary tufts or glomerulus, and these in between the areas, this is very important areas that we call the mesangium, which contain some of the mesangial matrix and some of the mesangial cells. So what is written? Let's see here. A normal glomerulus is shown diagrammatically. Note the relationship of the capillary loops to the mesangium. About 15% of the glomerular filtration occurs to the mesangium. So 15% to the mesangium, with the remainder through the fenestrated endothelium. So mainly through the endothelium, and here's the 15% glomerular filtration also through the mesangium. The normal anionic charge barrier of slit pores in overlying podocyte cytoplasm prevents large protein molecules such as albumin from passing through the visceral epithelium. That's why albumin is never transmitted, yes, through the glomerulus. The normal mesangium contains about 2 to 4 mesangial cells. So these are 2 mesangial cells which have a macrophage. So mesangial cells, macrophage-like function. So here's the summary talk, you see. So this is the tuft of capillaries. So this is the lumen, endothelial basement membrane, and epithelial, some of the food processes, the porocytes. And among these three, there is a mesangium matrix, mesangial cells, and these mesangial cells are nothing but the M for macrophage. Another slide, you see, same slide, but here is some more information. So glomerular capillary pericytes are called the mesangial cells, so it's a pericytes. This produces the mesangial matrix, which is supporting framework for the glomerular basement membrane, and is chemically the same. Means the matrix and the cell are same. Mesangial cells are contractile, helping regulate flow and filtration rate in the glomerular tuft. So these are contractile, some of the helping, some of the regulating flow and filtration rate also in the glomerular tuft. So this is the glomerular structure once again. So yes, the mesangial cells are pericytes. Mesangial cells are macrophage-like action. Mesangial cells having role play in the glomerular filtration rate as well. Normal glomerular structure. So these are real pictures, matter some of the histopathology slides. So let's see. These are normal glomerulars by light microscopy. The normal glomerular capillary loops are thin and delicate. Endothelial and mesangial cells are normal in number, and the surrounding tubules are normal. Life is good. So I listen very good. Having the glomerulus, the different tufts of capillaries. So these are the capillary lobes. So say the capillary lobes are thin and delicate, and having the endothelial cells. So having the endothelial cells, some of the endothelial cells are seen here, and the mesangial cells. So these are the mesangial areas. So normal in number. So one or two, some mesangial, you see the two cells. So this is the important, the glomerulus having the capillary loops, having the endothelial cells and also some of the mesangial cells. So the word, my dear, so capillary loops, endothelial cells, some of the mesangial cells, and the basement membrane. Yes, my dear doctor. So normal glomerular structures are more magnified, and along with that, these normal glomeruli stained with the pass to highlight basement membranes of the glomerular capillary lobes. So see the glomerular basement membrane and the tubular epithelium. The capillary loops of these normal glomerulus are well defined and thin. So these are capillary loops. Capillary loops, you see, the well defined and very well defined and thin and delicate. Endothelial cells are seen in capillary loops. So you see the endothelial cells. One of the endothelial cells is seen. One of the endothelial cells are seen. The mesangial regions are normal size, and once again the mesangial region is the normal size. Porocytes are present, forming the visceral epithelial surface. So this is some of the porocyte, and this is the Bowman's capsule, and having some of the parietal cells, So this is the visceral layer and this is the parietal layer. So yes, Bowman's capsule. So once again the Bowman's capsule having some of the parietal cells, epithelial cells. So once again this is the tuft of capillaries. The capillary lobes are normal, thin, delicate, well defined, and some of the endothelial cells and some of the mesangial areas, the normal cell number, and some of the porocytes here, and this is a Bowman's capsule, and this is the parietal cell. Now start with some of the glomerular disorder, my dear. My dear, listen very carefully. You already have gone through the video lectures of glomerular disease. You can remember the glomerular disease starts with one of the important box that you already learned, the upper respiratory tract infection with the glomerular disease presentation. So the first and the most common that you need to think about the IgA nephropathy and the PSGN, means the Post-Streptococcal Nephritis. So IgA nephropathy, the another name of IgA nephropathy, that is nothing but a mesangial-proliferative glomerular nephritis. I put the MPGN, I put a small s so that it will not be confused with the membranous proliferative glomerular nephritis. So my dear, listen very carefully. IgA nephropathy is nothing but the mesangial-proliferative glomerular nephritis. The word itself tells that the mesangial deposition of IgA antibody. So yes, my dear doctor, let's see in this slide what is shown here. In IgA nephropathy, there is an abnormality of glycosylated IgA1 anti-glycan antibodies form and lead to immune complexes deposited within the mesangium of the glomeruli. So the word, yes, the mesangial deposition. I say that this is the mesangial deposition. These complexes attach to the fibronectin or type 4 collagen in the extracellular matrix and activate the mesangial cells to produce the extracellular matrix, leading to mesangial hypercellularity. So you can see the mesangial hypercellularity in contrast to the normal glomerulus. Yes, the mesangial in contrast here, the many cells here. So mesangial hypercellularity. These complexes, yes, segmental glomerulosclerosis and adhesion, tubular atrophy, and interstitial fibrosis. The IgA is deposited mainly within the mesangium. So the word that's really helpful. IgA is a mesangial deposition, and then increases the mesangial cellularity as shown in the arrow. So here's the mesangial cellularity. You see the number of cells 1, 2, 3, 4, 5. That's because we learned that the number of cells only the 2. You see the normal structure in the mesangium, the maximum 2 to 4 cells. Yeah. But in contrast with the IgA nephropathy, you see the 1, 2, 3, 4, 5, 6, 7. So many cells of mesangial proliferation. Patients with the IgA nephropathy usually present with the hematuria. Older adults may also have proteinuria, microscopic hematuria, hypertension. Most cases are idiopathic. Some cases occur when there is a defective clearance of the IgA with the liver disease. Yes, you will have the lactose of the IgA nephropathy. The A for alcoholic liver disease, which will have the defective clearance of the IgA leading to the IgA nephropathy, and also some other associations that you'll see, some of the celiac disease as well. So what I'm saying, my dear, this slide, the aim and objective is the mesangial proliferative glomerular nephritis, the mesangial proliferation. This is one of the important points that you need to remember, my dear. IgA nephropathy is an immunofluorescence. IgA nephropathy immunofluorescence pattern demonstrates the positivity with antibody to IgA. Note that the pattern is that of mesangial deposition. The words are really, you see, these are the mesangial deposition. So these are mesangial deposition of the glomerulus. Some viruses and bacteria express the N-acetylgalactosamine on their cell surfaces so that infection may promote anti-glycan antibody formation. IgA nephropathy may initially appear in association with an upper respiratory or GI or gastrointestinal infection. Some of these patients progress slowly to chronic renal failure. In this course, there may be gross hematuria, often within the 3 days following a respiratory tract infections. So the immunofluorescence showed that the IgA positivity, and these are mesangial deposition. In contrast to the IgA nephropathy, related to the upper respiratory tract infections, we put the name of IgA nephropathy and skin infections, means within the 2 to 3 days, maximum 5 days. In contrast to the PSGN, post-Streptococcal nephritis, is in weeks. It needs the 2 to 3 weeks, and at least the 10 days after having some of the upper respiratory tract infections. So we call the PSGN, and we put a name is very much important. The DPGN means the diffuse proliferative glomerular nephritis. You see this slide having the number of cellularity. Yes, the diffuse proliferations of the number of cells is increased diffusely, whatever the size. You see this slide and against the slide, the normal slide here. So yes, the number of cellularity is increased, diffusely increased. So that's why the glomerulus is hypercellular and capillary loops are poorly defined. Yes, in contrast to the normal, the capillary loops are, yes, well defined, delicate, thin. In contrast, the number of cells are increased diffusely. And the type of proliferative glomerulonephritis known as the post-infectious. In this case, followed a group A beta hemolytic streptococcal infection occurring 3 weeks earlier, and thus it could be termed the post-streptococcal nephritis. We call it PSGN. We call the DPGN. So once again, my dear, what 3 serological tests that has high sensitivity to PSGN? Very important, the ASO, anti-streptolysin, the anti-hyaluronidase, and AD at anti-DNSB are 3 tests highly sensitive to detect an immunological response to the prior group A streptococcal infection. So these are the knowledge that you can add there. So so these 3, make a box and learn them. So my dear, what is the term? Upper respiratory tract followed by some of the glomerular disease, the 2 disease IgA and other was the PSGN. IgA is nothing but the mesangial proliferative glomerulonephritis, mesangial deposition with the hypercellularity. In contrast, the PSGN is nothing but the DPGN, the diffuse proliferations. These 2 important words that would be helpful to differentiate in between these 2. In contrast, here is the PSGN, once again the higher magnification. Same thing, the hypercellularity, the number of cells in epithelial, endothelial, mesangial, as well as the neutrophils in and around the glomerular capillary lobes. This disease may follow several weeks after the strains of group is beta hemolytic streptococcal. PSGN, once again having some of the immunofluorescence that the immunologically mediated and the immune deposits are widely distributed within the capillary lobes. The deposits are seen here with the bright green fluorescence in a granular bumpy, the word that are really helpful here. Pattern because of the focal nature of the immune complex deposition process in type 3 hypersensitivity. So PSGN is a type 3 hypersensitivity. Antigen antibody complexes tend to filter out and become trapped along the basement membrane, such as those in the glomerular capillaries. So the PSGN is an electron microscopy, what it shows that. Very important slide, my dear. This is very important. The immune deposits of the post-infected PSGN, predominantly the subepithelial. The immune deposits are subepithelial. The word is really important. As seen above with the electron-dense subepithelial humps. This humps word is really important. And the basement membrane and below the epithelial cells. The capillary lumen is filled with leukocytes demonstrating cytoplasmic granules. So this is the subepithelial humps, my dear. So these electron-dense subepithelial humps, the word humpy, lumpy is the PSGN. If I make once again a box with a PSGN, just say the word, that's a really important, the P. P means, say me, PSGN, P for humpy, bumpy, and this is nothing but the subepithelial. So yes, the electro-dense deposits will be onto the subepithelial humpy. P, PSGN for the P for humpy, humps. And these subepithelial humps is very important. And also the diffuse, once again the DPGN. But the most important, the subepithelial humps is a very important features, my dear, in electron microscopy. So somebody talk here, in a DPGN that we can see the diffuse proliferations of all the cells, including the neutrophils as well. So you see the diffuse proliferations, and the immune deposits will be the subepithelial humps, humpy. PSGN is an humpy. In contrast, is an IgA nephropathy, is a mesangial proliferation of the cells along with the mesangial IgA deposition. Next to the IgA nephropathy and also the PSGN or DPGN, we learned the nephrotic syndrome. In a children, C for children is the C for change, means the minimal change. It is the most common. And also the nephrotic syndrome in adults, the most common is an